Good morning. My name is E.Czerwinski. I am Professor Emeritus of the Jagiellonian University and Senior Medical Director of PHARMACOLOGICAL. I'd like to invite you to observe a presentation I had in Delhi, India, recently. International Symposium on Bone Health, which was held on 9th of November this year. And I was talking on progress in pharmacological management on osteoporosis. I was invited by Professor Srivastava, and unfortunately it was online presentation, but I hope to be there next year. This reminds me my first trip to India in 1975, when I used to be the director of scientific program and as well as the doctor of expedition to India, which was towards investigating of endemic fluorosis versus industrial fluorosis we had in Krakow. And let's remind you that the endemic fluorosis occurs in era when the fluoride content in natural drinking water is more than 10, even 20 ppms. It causes classical motley enamel and overgrowth of bone. Even there were cases with the overgrowth in the spinal cord, spinal canal, and producing even the paraplegia. Fluoride was a medication for osteoporosis, but we generally overdose. So it just was stopped forever. My host was Professor Teotia in the university. It is her team, his team, and our expedition. We're traveling 3 months on track. This was the greatest adventure in my life. This was organized by Professor Skalski. It was very comfortable. We have our hotel on wheels, 4 stars. Saying that, please watch my presentation recorded. Good morning from Poland. My name is E.Czerwinski. I am orthopedic surgeon involved in osteoporosis for some years. And I'd like to thank very much Rupert Srivastava for inviting me to this important international symposium on bone health. This is a great honor and privilege to me. I'd like to discuss with you the issue of the progress in pharmacological handling of treatment of bone osteoporosis, which increases the bone quality and prevent the fracture, what is my main interest, of course. This is our Royal Catherine Krakow. I am from, and my agenda for today is antiresorptives in view of bone remodeling, mean bisphosphonates and Denosumab. Then bone forming medication means the TH analogs, Denosumab, and brand new AJ 2118, and of course then summing up. This is just the corner of Poland on the border with Ukraine. So all of us know the remodeling starts the first on the activation phase, then we have resorption, and then the reversal phase, and new osteoid formation, mineralization, and it goes again and again every 150-day cycle. It is change in osteoporosis. We have more osteoclast, more active, deeper bone resorption, smaller reverse surface, and we're ending with a very small amount of bone. And antiresorptive drugs just prevent the bone resorption. And the oldest one among all registered is alendronate from 1995. And the main action of bisphosphonates is the binding hydroxyapatite producing binding hydroxyapatite, what makes it less soluble, so less resorption. However, the bone metabolism is controlled by bone cells, and the osteoid side is the orchestra conductor, a great communicator. It takes care of bone quality. I am not going to talk about, there are many books of the whole relationships within the cells. And I start definitely with rangligan, which is one of the stronger bone influences quality, is excreted by osteoblast, which stimulates fusion and activation of osteoclast. Therefore, the antibody, the Denosumab, prevents that action, and there is no more osteoclast, so there is no bone resorption. It gives a very huge increase of BMD. After 10 years, we observe 21% in the lumbar spine, as we compare to adrenate, half of that, and also big increase in total hip, 9.2%, while alendronate gave us 7%. And if we will take into consideration just the clinical trials and put bisphosphonates in the order of the higher decrease rate of fracture risk. So here we have on the spine, so randonate, denosumab, ibandronate, adronate. By roughly talking, it is about 60% reduction of the fracture risk. And the femoral neck, alendronate, zonrandronate, denosumab, riserdronate, ibandronate, more or less around 40-45%. So they're quite similar. If we go to the current literature reports, and what's the more important, the efficacy of the prevention of the secondary fracture after the first fracture. So we see that all of them are effective in similar degrees, means denosumab, zoledronate, alendronate, riserdronate. So all of them are effective in what is the crucial prevention, the next fracture after the first fracture. However, the recent reports on real-world evidence with huge data of US Medicare based on 400,000 of women prove that the long-term there is a higher decrease of fracture risk due to denosumab as compared to alendronate. It relates to major osteoporotic fracture, hip fracture, non-vertebral, and even non-vertebral without hip. Here we have the comparison of the 8 years, but please take care about this graph, and we see that in 10 years, in case of denosumab, we had constantly increased bone BMD. However, bisphosphonates, after say 5 years, there is no further increase of bone density. So this is perhaps why the right with data we have this finding that the Denosumab reduces fracture risk in the bigger extent than alendronate, another of bisphosphonates. So you can treat osteoporosis for life, like we do in hypertension or diabetes. However, there is a concept of treat to target, because if we watch the decrease of T-score, so after minus 1.5, there is no further decrease of fracture risk. It is proved in the total group, in age-related group, and with the fracture, broken group with a fracture. So it is generally suggested that if you reach the target means between T-score minus 2 to minus 5, you perhaps can, or maybe you should stop the treatment. In case of bisphosphonates, even after 10 years, 4 years, we see that there is, even if we stop, there is still the same level of bone of BMD change, like no change, means because bisphosphonates remains in hydroxyapatite for 5 or maybe more. But this is definitely opposite situation if we stop the Denosumab, because if we stop it, we have a very quick rise of the bone resorption and bone forming bone markers. It goes even in the higher degree than it was before, and it reflects also decrease of the bone BMD and increases fracture risk as it was at the beginning of the treatment. There is some explanation for that phenomenon. The one is activation of sleeping pre-osteoclast, other is abrogation of RANKL. It was quite a big surprise because we thought that Denosumab is the best ever medication for osteoporosis, but in fact there always can be something better. So here you have the BMD change after stopping Denosumab. So if we do not anything, we return to the starting point, but we have to admit the resorption or arendronate or zoledronic acid is preferable. However, it doesn't prove to full prevention on the BMD loss. And what's even more important is the fracture risk. Here we have the group of placebo, and the fracture risk during the first year of the trial was 7%, and after discontinuation, 8.2. And here is the group of the Denosumab. So under the treatment, the incidence was 1.5, but after discontinuation went back to 7.1. I mean, almost the same as it was before the treatment. So we lose everything what we gain before the treatment. So that's the big question. So these were the antiresorptive, and now I will move to bone modeling and bone forming agents, mean PTH analogs, then Denosumab and dual action AG A2118. In remodeling phase, we have first resorption by osteoclast, and then reversal phase, and again, and remodeling, we have just stimulation of osteoblast without need of bone resorption, what gives a bigger and quicker increase of bone density. In normal world, PTH is a hormone which stimulates osteoclast, increases bone resorption, and produce secondary osteoporosis. This we know. But given intermittently, I mean every day, and then stop. So the first phase, we have stimulating effect to osteoblast precursor and itself osteoblast, and also we have a coupling effect due to first of cytokine trap effect B, or when the restoring bone release of TGF beta and BMTs, which stimulates osteoblast. Giving PTH intermittently, let's say daily, there is at least 23 hours time for bone formation, while it will be permanently, there will be first index, the bone resorption. So here we have the bone forming drugs. Parathyroid derivates mean teriparatide, abaloparatide, and Denosumab is the anti-sclerostin antibody. So here we have the comparison of the effect of teriparatide and risdiplam and the time of the first fracture. In the blue is teriparatide and the green risdiplam. So in 24 years, we have almost 3 times higher incidence of the first spinal fracture in risdiplam. And the same or similar relates to non-vertebral fracture. After 25 years, we have incidence about 2.5 and incidence just 5 in risdiplam. Teriparatide proved also decreased the hip fracture. All the studies and these results are permanent even after stopping. So here we have the stopping after 18 months and there up to 36 months. There is still the same level of fracture risk reduction. So these were the analogs. And now Denosumab is the other piece of regulation of osteocyte. Osteocyte produces sclerostin when it's unloaded, and this stops osteoblast. So if we withdraw sclerostin, we have increased osteoblast action and decreased osteoclast resorption. The two prominent studies, the first was FRAME for 7,000 women, where we have the first Denosumab versus placebo, and then Denosumab up to 3 years. And because in osteoporosis head-to-head study, where you have Denosumab compared to arendronate, also 3 years, 4,000 women. So we compare the efficacy simultaneously in the same group or similar groups, Denosumab and arendronate. And here we see the increase of BMDs in spine. So after 36 months, we have 14% gain in Denosumab, again to 8.5 to arendronate. And the same is in total hip. After 33 years, you have 7% increase of BMD as compared to 3.6 in arendronate group. What's of course more important is the fracture risk. I just want to remind you it is head-to-head study, so everybody was treated either by Denosumab in red, either in arendronate, and we see that the clinical fracture is lower in Denosumab group. And what's the most striking that the reduction of hip fracture as compared to arendronate is 38% lower in those who were treated with romosozumab. Not every drugs are the same. Here we have the comparison of teriparatide, abaloparatide, romosozumab, and we see that the increase of the BMD is highest in romosozumab in lumbar spine, and the same relates to the femoral neck. The same relates to the what could be expected fracture efficacy. Here we have alendronate, denosumab, teriparatide, and romosozumab. So this was a story of anti-sclerostin romosozumab, but in the latest SBMN 2024, there was the first announcement of the AIIMS 2118, which is W-way antibody, which stops both sclerostin, which activate the WNT, and DKK1. DKK1 is perhaps even stronger, but maybe not. But if you stop both of these cytokine DKK1 and sclerostin by one medication, you will receive almost double action. This is the report, and after 3 months, 2.8 months of AJ 2118, we have 11% decrease in the lumbar spine and 5.3 in the total hip. This is the result which we observe even in the agent, bone producing agent after a year. I cannot resist to declare and to remind you that almost every non-vertebral fracture results from a fall. So the fall prevention and physical activity is inseparable in prevention on the osteoporosis treatment. Every my patient have with me a discussion, not only on medication level of beta-amide, also asking about activity. My prescription is Nordic walking 1 hour twice a week at least, and I check in every patient visits. Let me cite Wojciech, who was the doctor of 3 Polish kings, and he wrote that no drug can replace physical activity, but physical activity can replace many drugs. So leaving you with that, let's do some home take message. First is about antiresorptives, which are very long time in the market and are very efficient and not many complications, are they safe? And the Denosumab give faster bone increase and is more consistent in long-term reduction of fracture risk. Bisphosphonates remains with bone for many years, so discontinuation is not a problem. Why it is a huge issue with Denosumab, because if we stop Denosumab, we have sudden increase of bone markers and BMD level, and fracture risk just return to the baseline. So we have to prevent that, and give currently zoledronate is the preferable medication. It is striking that PTH, which is known as bone resorptive, active, have hyperparathyroidism, known as the second osteoporosis reason. So cyclic regimen from teriparatide, apartheid, stimulate bone formation and gives a very huge increase of bone quality, bone BMD, and decreases fracture risk. Romosozumab is a sclerostin antibody, and head-to-head study demonstrate its greatest efficacy in prevention of fracture. It was as much as 38% in case of alendronate. I remind you, two head-to-head groups, one on alendronate and another on the romosozumab. Bone medicine, bone building medicine give faster and greater increase in BMDs and greater reduction in fracture if we compare to the antiresorptive. If you are talking of the indication approved by BAD, so romosozumab demonstrate the highest increase of BMD as compared to teriparatide and abiraparatide. A brand new report, the 3-month treatment of AGA 2118. It is biospecific antibody neutralizing both DKK and sclerostin causes increase in 3 months BMD as much as the other bone forming agent have in 1 year. And let me remind you that almost 100% of non-vertebral fractures will fall. So for prevention and physical activity is really inseparable component of osteoporosis treatment, and this is what I do with every my patient. And I cite again the doctor of Polish Kings that physical activity can replace many drugs, but no drug can replace physical activity. Unfortunately, patients and many doctors don't understand that. And they believe that if they take a pill, they will avoid any fracture. And this is not true. Saying that, I wish to thank you very much for your attention. I'll be happy to take some questions. Thank you very much.